My name is Kwame Liddell. I'm the founder and CEO of ThriveLink. We make artificially intelligent agents that talk to families for hospitals and health insurance plans, and it navigates them into social programs like food stamps or even schedules rides for them to their doctor's appointments.
I'm Mo Nandi. I'm the co-founder and CEO of Monier. We make a solution that uses AI to detect anemia from your eyelid. And we make this solution for last mile health worker, governments working in, and foundations working in global health. And it's also targeted for women in general who are the who actually have the anemia, mostly more than 30% in the world.
We're from the same organization, Equitech.
No worries, Nikita. Well, hi, I'm Chi-Ling. I'm founder and director of Equitech. We build equity advancing technology in Southeast Asia and deploy AI solutions, including clinical decision chatbots in countries such as Timor-Leste, Cambodia, the Philippines, and Thailand. How do we pass this over to Nikita as well?
Yeah. Hi, everyone. My name is Nikita. I lead partnerships at Equitech, and I'm also the project lead for Medibot, which is the AI clinical decision support chatbot that got selected for MIT Solve. Thanks. I'll pass it to Mamoon.
Hi. Yeah, thank you, Nikita. Hi, Kate. So this is Mamoon here. I'm one of the co-founders of Med AI. What we do is we build inclusive AI solutions to ensure that patients who have been historically outside digital health frame can access digital health services more easily. We basically make voice interactive triaging clinical recommendation system that patient can use in their native language so that digital health becomes much more accessible. And we tackle clinical decision support biases, which are predominantly trained on European patient data. So we train inclusive clinical decision support systems by including disease prevalence and risk factors of ethnic South Asian patients. We are operating in Bangladesh at the moment, and we would like to expand our solutions to more in the South Asian region of South Asian ethno-linguistic groups.
Fantastic. And quick question before we go more into the AI itself. You are all intervening in South Asia. Kwamane, where are you located?
I am in Utah, United States. We do have a subsidiary in India, but we also have our application being used in Brazil, Zambia. Actually, it's being downloaded and used in many other countries, which we always don't track. So, yeah.
We are headquartered. Oh, go ahead.
No, Kwame, go ahead. Go ahead.
Sure. We're headquartered in St. Louis, Missouri. Most of our users are in California, Missouri, and North Carolina.
We are based in the UK, but then because there is a large ethnic Bengali populations here, so whatever solutions we are building for the Bengali communities in Bangladesh, we are working with some of the NHS partners to try to see whether we can deploy them here, because there's a huge health equity issue within the NHS for ethnic South Asian patient populations.
And all of you are using
the Equitech Singapore. So we are, no worries. Equitech is headquartered in Singapore, but we serve various countries across Asia.
And you guys all use English with your bots?
No, so I'm a doctor. I think that's one of the value proposition, that our entire voice interactive system, the clinical it is in Bengali. So there is an English version available because of mapping, that let's say if we want to map next to Hindi or Gujarati or Assamese. So English is the foundation backbone where a lot of technology is developed, but then parallelly, we are heavily on the Bengali sort of language at the moment.
Fascinating. Maybe in terms of getting really the most out of your respective perspectives, could we do a round table as we did before, where everybody just explains briefly the scope and objective of their mission? That would be very helpful.
Let's go in the same order as introductions.
Hi, at ThriveLink, we really think about, and our mission is to make the world more accessible for seniors, people with disabilities, and people who have literacy barriers that prevent them from navigating the healthcare, government, and social care ecosystem. Our vision is that anyone, by just speaking, can access the resources that they need, and that's the power of ThriveLink, because you don't need a smartphone or the internet to be able to navigate it. Just a simple conversation makes the world more accessible.
Okay, so at Monear, we serve global health, last mile workers to use our solution, which is a smartphone app, to use and take a picture of the eyelids and detect anemia or hemoglobin level within a few seconds. So our customers are foundations, not-profits, governments, and our users are women or children, adolescents, girls, and whoever having anemia and being served with global health equity foundations and governments. We're also releasing a version for self-monitoring this Women's Day, March 8th, like in a week, not even a week. But the reason is that even in developed countries like United States and Canada, the number or percentage of iron deficiency and iron deficiency anemia among women and girls are really, really high. More than 40% for adolescent girls and 1/3 of the women. They don't know, they're severely underscreened. So having this app in their phone will help them know where they're at and take intervention early in the process, so prevent or reverse anemia. And also 63% of LMIC women have access to smartphone. So self-monitoring is possible even in other countries in the world, instead of just waiting for the last mile health workers to take the service to them. So that's who we serve.
At Equitech Collective, our mandate is really to build equity advancing technology to improve healthcare and education in underserved communities across Southeast Asia. And we have a few ways this manifests in terms of products and beneficiaries. So our flagship project was actually a lightweight electronic health record system for a health clinic at the Thai-Myanmar border, serving about 250,000 refugees. Apart from that, we've also built AI clinical decision support chatbots for under-resourced doctors in Timor-Leste. And we also have a new tech product coming out for patient remote monitoring and case management. Our operations, so headquartered in Singapore, but we have operations across Southeast Asia and expanding into Asia Pacific, Australia, New Zealand, Timor-Leste as well. Shilin, would you like to add anything?
Yeah, sure. The fundamental problem that we are trying to solve is one around breaking the iron triangle of healthcare, which is solving the trade-offs between access, cost, and quality. The truism is that of the three, health systems can only select two to optimize for, and we believe that technology can break this trade-off to actually achieve access, cost, and quality for all health systems. We do this primarily by supporting health systems that are interested in innovating asynchronous care models. So the product that Nikita mentioned earlier is Speedback and Medibot. So these two products, Medibot serves LMICs and Speedback serves public health systems in more developed economies like Australia, New Zealand, and Singapore.
I guess for us, the mission is yes. I think tackling the health inequality, and I'll just try to very briefly unpack one What do I mean by inequality? I think we started from a position where we saw the clinical decision support systems are becoming very popular in the developed world, and very soon they started to deploy it in the developing world. Where we noticed is that a lot of these are trained on European patient symptoms, their diseases, their vocabularies, how they describe their medical problems. And a lot of these doesn't really take into account the risk factors, the disease prevalence of ethnic minority patients, or at least in this large South Asian communities. So we built that first. One of the things that we built was a kind of inclusive clinical decision support that can help doctors to reduce consultation times, take recommendations from AI to provide consultation much more faster. So basically increasing efficiency in the operation and clinical delivery, operation delivery. But then when we started deploying our solutions in Bangladesh, we noticed that, okay, a lot of people have smartphones, but they're not able to type because they're not literate. And there is a technology access barrier. Then we saw that, okay, let's just try to use Google speech to text. And we saw that if you're trying to order a pizza or looking for a bus station, the Google speech to text and the translation service works quite well. But as soon as you try to describe your medical problem in a particular Bengali dialect or any other South Asian dialect, it doesn't really work very well. Then we started building a medical speech recognition where the patient can come and describe their problems in their own language. So if you kind of stitch some of these components together, our main objective is to make sure that patients have access to technology. So not so different from Equitech and quite a few other people here, that patients can access that essential primary care services in their native language at ease without going through the technological hurdle. And on the other hand, using the recommendation system, healthcare providers have access to these AI solutions, recommendation systems that can increase efficiency of delivery, but they are not biased. They can be deployed, because one of my concern is that we know that technology can actually gaps healthcare kind of delivery systems existing problems. But if we don't make this technology inclusive, one, we leave a large segment of the society behind, that they will not benefit from these digital tools. And the second is, once you deploy a biased recommendation system, it will just keep rolling on. Nobody will actually then roll it. So it will systematically exclude a large segment of the society. And that's what our mission is, to, in every single aspect, whether that's creating health education contents to supplement the doctor's prescription. Again, it has to be culturally appropriate for the patient. So this is another dimension that we are trying to address, is that trying to do a complete circle of healthcare delivery, where every single component, whether we bring AI or not, it has to be inclusive.
Oh, Cornelia, I think you're on mute.
Anyone else wants to jump in? I feel that there's always this time gap somehow in between the transmissions. So in terms of hurdles, let's say, what would be, if we go around the table, what would be the biggest hurdle that needs to be overcome, you guys think, to make AI really this force for social good that it could be?
I can have a very brief go at it. I think adoption is a huge challenge among many, whether doctor or a patient. As soon as you say AI, once it basically triggers some excitement, but also a fear. In doctors, many doctors, they fear that AI is trying to take their job away. So trying to, I guess, at the moment there is a buzz in the entire industry, health or otherwise, AI, AI, AI. Everybody wants you to use AI. And we were kind of also, in a sense, pushed to use AI in many of our branding and everything. But essentially, our objective is to deliver a solution that works. Whether we do that with AI, without do it AI, it doesn't really matter. But this is a kind of double-edged sword, is that you need to use AI to interest stakeholders, whether that's your investor, whether that's your funder, because it has to have an AI element. On the other hand, for an ordinary user in Bangladesh who's trying to use a smartphone to talk to a doctor, and then they don't really care whether I'm actually giving this with an AI or not. A young techie kid might. I think sort of in case of Monero, in case of Equitech, every case, we're just trying to build a solution that I think AI is just a tool that we want to, but as soon as we say AI, to our end users, there are different reactions. I mean, I don't know what others think.
In a way, we're coming back to the old thing that preceded AI and will probably long keep on lasting, is that we can't expect for the technology of tomorrow to be better than the humans of today.
Yeah,
Any other thoughts?
Yeah, just to add on to what Mamoon said earlier, I think a lot of our ethos is you have the technology, but that's only one part of the equation. How do you build capacity on the ground so that users can actually derive value from that technology? Especially because the work we do is often with underserved communities who have, for example, never interacted with a chatbot like ChatGPT, for example. So tech is one part of the equation, but implementation, adoption, user training is maybe even a more important part of the equation to really have successful technology. So for our use case in Timor-Leste with Medibot in specific, we have to do a lot of user training with the doctors on the ground because they have never interacted with a chatbot before. And for us, our product is Medibot, which is a clinical decision support chatbot. So it requires them to go on to WhatsApp and ask any types of medical questions, and then they receive answers. But a very simple user insight we had from user testing on the ground is, as doctors were asking questions to the chatbot, they didn't realize they could ask follow-up questions. So for example, they would ask, I have a patient with XYZ, what is the diagnosis? And then they would want to know about treatment, but they didn't know they could, probe the bot a bit more. So just things like that, user behavior, how can they derive value from the technology you're deploying? I think that's a huge, maybe even more important aspect of the equation, and really links to the adoption aspect that Mamoon talked about earlier.
And I think they're to put the onus, a bit of the onus on AI companies. It's also important to have user-centered integration, user-centered integration, or human-centered integration, because it really underlies the real underlying adoption issue is one that is new. So with these new capabilities, we have to be really good educators. We have to be really good at making sure that our end users and customers understand the new, it's a new world of possibilities that has never existed in technology. Like even the example Nikita used, they didn't know that they could go back and probe it because historically they could not go back and probe it. And really thinking through for us with telephonic AI, historically, if you call an IVR system at a bank, it doesn't do much. But really making sure that we have that human-centered interaction and integration, we've been able to overcome a lot of those barriers by being really, really, really good educators and really clear at showing off, if you will, all of the great capabilities that are possible. And I think when you're able to do that well, people get excited, and people begin to even ask for more, which is really delightful because AI just has so much potential and so many capabilities.
I would like to add a few more. So we do not use LLM. Our AI is a computer vision AI. So it's a proprietary AI which we created from collected proprietary data. So data collections for creating foundational model or new model from scratch is challenging. And when we're trying to build a model for all women, we have to get data from different population. So it covers the variation in the population, their race, ethnicity, medical history, all of this. So that has been a challenge initially. After MIT solved, it has become a little bit easier. People know that you want a global health equity award, so they want to talk to you, they want to give you data. There's distrust for people who take your data, because there has been instances people take data and use it for different purposes, not what they say. So, and many LMICs, IRB, like in the review board protocol, ethical boards are not regular. They don't go into monthly or weekly basis and look at your proposal and approve that. So that delays the thing, delays the whole process. Adoption is a problem. Last mile workers, not only they require training, they also resist using it because it changes their current process. It's a changing process. Most people, not everybody, most people do not like change. So it's kind of pushing from the top that you have to actually get this because there's impact. It takes half the time. It doesn't require audit, which could be a problem because you don't require audit anymore. It's all automatic. So there's this resistance also. The another part of it is that I forgot. There was another one I was going to say. The funding. Nobody says about money, but money in global health is not available really. It's very hard to get that money. No VCs will invest in you if your business model only covers global health. So you have to have a different business model in order to get money to grow or create a AI algorithm, which is extremely expensive because you need these GPUs. Those are expensive. The data center resources are expensive. So that's another roadblock there.
And let me pick you up on this one. What's the business model that all of you have? Like, do you depend on external funders? Are your users the ones who are paying? How does it work?
We sell to hospitals and health insurance companies. And we really designed it. It was an important thing to think about because AI could do so many things. It was important for us to understand what are the things that you need now. And I always refer back to just that human-centered integration. When we first talked to hospitals and really wanted to understand what are the things that doctors and your patients need that would deliver the most value. Then we went back and designed how our interface would navigate it. So what we do, we sell AI agents that talk to their patients and navigate them through to their next appointment, to sign up for various programs, even to make their medications more affordable, because the hospitals struggle deeply with hiring enough staff that once the doctor says, hey, go take this medication, and if a patient had any barriers to actually do the work that was necessary to follow their care plan, it was really expensive for hospitals to hire more people. So where we saw the opportunity was to bridge a gap in a gray space, a gray area where it's not replacing people, but they would really, really, really love if they had people who could do this. So really, we created technology that was in this open area where they really needed help and integrated easily into their ecosystem. So now they purchase subscriptions.
I can share a bit more about the business model that Equitech takes. For our low middle income countries, we do not charge our end users per se. At best, it would be at cost. Some of the health institutions that we work with, we cross-subsidize this low middle income countries' work through our social enterprise that serves hospitals and clinics in more developed markets, such as in Singapore, New Zealand, and Australia, and that generates a more longer-term source of revenue to cross-subsidize our non-profit work in the low middle income countries like Timor-Leste, Cambodia, and Thailand, the Philippines.
Sorry, no more, go ahead.
Sorry. Okay, I'll go. So the business model we have is selling to foundations who actually fund nonprofits work. We did have a sale, a big one, like 1 million tests sold to one of the foundation, and then governments. The problem is that the sales cycle is really, really long for governments, any government for that matter, and you have to sustain in the first few years to get there. We are launching this self-monitoring app that we're trying to do an experiment to see whether we can do B2B or even B2C, depending on that result. So B2B would be also Plo, if you know this app, period tracking, cycle tracker apps, the Plo, Natural Cycle, Clue, Pregnancy Plus, they track women health. The underlying factor, the basic thing is iron deficiency, which they don't track. We are trying to see if we can integrate with them and provide that feature through their app. So depending on our experiment and response from them, we'll go for that.
I'll just add so we adopted kind of sort of mix of B2C and B2B. Basically, I think what sort of Chilling said for Equitech, we kind of had to do a very similar thing within Bangladesh, not even LMIC and then affluent countries. So even within Bangladesh, we have a subscription model and then business to business corporate kind of partnership models where we offer subscription and then B2B services like clinic digitization services using our platform, so that the revenue that we generate from there, we have few subsidized projects going on. One of them is that we offer heavily subsidized virtual consultation and healthcare access facilities to female workers from the ready-made garments industry and their community. We are also trying to do a partnership with a company called Food Panda, which is again lower social income group, young workers who work as a rider, food delivery. So this is kind of like Deliveroo in Bangladesh. It's a Malaysia-based company. So there are 18,000 lower socioeconomic group workers working. So we have that B2B angle so that we can generate enough revenue to subsidize within the same country. Some of the communities, they're quite underserved and then under-resourced to access healthcare. So it's a mixture of B2C and B2B.
I also wanted to take a moment to, sorry, Cornelia, just to make sure that Julian also had an opportunity to introduce himself, and sorry for the calendar mix-up.
So I can give you a tiny little introduction into who we are. So I'm from the Open Flexure team. We design these microscopes, where I have one here. So it's a microscope that can be made locally in low and middle income countries, or well, in any country. So the hardest part of building a microscope is not the optics, which are generally quite easily available, but the rest of the structure that makes it function as effectively a robot that can look around at this micro scale. So the reason this is so important for health is so many diseases from malaria to cancer are diagnosed with microscopy. So the gold standard for malaria diagnosis is transmission light microscopy. But unfortunately, a lack of quality controlled microscopy causes over 1 million deaths a year, or contributes to over 1 million deaths a year from cancer and malaria alone in sub-Saharan Africa. So what we're doing is we're entirely a non-profit model where we produce the design for the microscope, and we're trying to enable local production of microscopes in sub-Saharan Africa and in other places by working with local manufacturers to get their quality control procedures in place so they can get regulatory approval to make medical devices in country.
Amazing. And if I now asked each of you to just give me in 2 sentences, what would be a typical user case? Like, I guess you have sometimes encounters with your clients or end users. One example, just very, very practical, how your application comes into use.
I'll give you one. In terms of self-monitoring, many women know they are anemic. They have to go to lab to get blood test and wait for the result. If they have our app on their phone, they can just do it at home, take a picture, and it gives you result within few seconds, 1 or 2 seconds, depending on the internet access. And they can know where they are even before they are very, very sick with anemia or iron deficiency, and they can take measures, early detection.
Anyone else?
I can go. So for our patient side, patients open our app. They, with an intention to find information about or booking a doctor or accessing some primary care healthcare services. So our voice interactive bots guides them through a series of medical questionnaires in their language, in patient's language, to accurately gather their medical symptoms, their prior medical history. And then based on that, we give a recommendation that they can book a specialist, which is available on the doctor, or we give a database of all the doctors in Bangladesh. And then they're able to book a virtual consultation. And once the patient books a virtual consultation, the doctor then receives an AI-generated recommendation with provisional diagnosis, possible diagnostic tests they need to provide to further probe and detect the disease, and even some generic medication suggestion. And then the doctor provides a virtual consultation on the platform, offers a prescription, and as soon as the patient receives a prescription, we supplement that by personalized health education contents in patient's language so that they can better manage their health.
I can go for Medibot. Specifically, the users are under-resourced doctors in Timor-Leste, and oftentimes they don't have the medical training doesn't sort of emphasize clinical based and evidence-backed medicine. So they have no access to clinical guidelines because it's in English instead of their local language. They have no physical or digital access to it. It's just cumbersome to carry lots of stacks of paper around and things like that. So we have made this process easier for them by creating an AI chatbot, which is trained on all these Ministry of Health guidelines, and it's deployed on WhatsApp because most doctors already use WhatsApp, and we wanted to prevent any user adoption barriers. So they can just go on WhatsApp, ask any medical question, and then the bot will provide an answer that is localized to the Timor-Leste landscape. And it's based, again, on MOH guidelines because there are very contextual nuances to the landscape, the medical landscape in Timor-Leste. So for example, Timor-Leste doesn't have ECG machines widely available, so the bot won't provide an answer. If a patient comes with chest pain, it won't say, go get an ECG. The other thing is it provides medical advice not only in English, but also in the local language Tetun. So being hyper-local and again, human-centric design is a big part of our process at Equitech too. Yeah, so that's how Medibot comes into their workflow. I'll pass it to Chiling to talk about Speedback as well. Chiling, you're on mute.
There we go. Thank you. Speedback is a chat-based platform that allows any doctor to scale their presence and trust with their patients. A lot of doctors are bottlenecked by the number of appointments they can have for synchronous visits by patients. And by creating asynchronous interactions, we enable doctors to build more trusted relationships in between visits, and also sometimes to substitute in-person visits. For example, in New Zealand, we piloted a model where community nurses who typically would do house visits and phone calls for blood pressure readings are now using Speedback. That's entirely chat-based. People can send a photo to us, and we do the extraction entirely automatically with AI.
Amazing.
For us, with ThriveLink, a use case is any person, typically it's older adults or people in low-income communities, who interacts with a doctor or a health insurance company. When they leave the doctor's office, ThriveLink will call them and say, "Hi, I see you were seen at insert hospital or clinic. Would you like assistance?" And it'll give them a list of things that it can help them with, like food stamps, utilities, affording their medication, or scheduling or a ride to their next appointment. And we built it all telephonically so that people can navigate it without having to have the internet or a smartphone and things like that. And I'll tell you something that's just interesting that we've learned in that experience is that older adults, regardless of their ability to read, they just prefer to talk and vocalize their answers to things as opposed to download apps or write it out on a piece of paper. And we also learned, especially in the Medicaid space in the US, more than half of Medicaid beneficiaries are children. And the thing that we're learning that health insurance companies haven't realized, because Medicaid engagement rates are often single digits, they haven't realized that the people that they should be talking to are Gen Z parents, because the majority of the actual patient are children and babies for the most part, and their parents are Gen Zs. So really, when we think about what we're seeing is incredibly high engagement in a historically hard to engage community, is because people in their 20s are comfortable with artificial intelligence. In fact, they prefer to navigate independently through technology to get to the answers they're looking for, when compared to having to miss work or schedule appointment, or in some cases for them, talk to anybody at all. So it's just some really, really interesting power and a new form of engagement that's taking place with artificial intelligence.
And if you project yourself in the future, and that's now a question for everybody once more, like 10 years into the future, what has happened?
I can say something.
Oh, go ahead, Julian.
Yeah, so I am realizing this is the AI call, so I'm going to try and AI focus this. But so there's a huge amount of research happening in the AI space for microscopy at the moment. All sorts of conditions which are prevalent in low and middle income countries have huge AI research programs looking at how to do digital microscopy diagnoses with AI. But actually, the current system, that if we don't do something over the next 10 years, is this will actually widen the healthcare gap between well-funded healthcare systems in countries like the US and Europe versus in low and middle income countries, because the problem in the microscopy space is not yet the lack of AI, but the lack of the digital infrastructure, the digital microscopy to be able to use AI. And so while we are focused less on AI now, we're focused on getting digital microscopes in country so they can be maintained and used in country. But that is the only way that we'll be able to ensure that all of these benefits of new AI diagnosis is available to everyone in the world and not just to the richest countries.
I think maybe a hot take. I think that most of the administrative and non-hands-on work, especially in healthcare, and I mean most, meaning more than 60%, will be done by AI. So things like scheduling appointments, things like navigating through your health insurance plans. I have Blue Cross, and their technology has already started and moved. It's actually quite good experience. So really, what we're going to see is doctors will do things that are hands-on. Nurses will do things that are hands-on. There will always be people with physical disabilities, and AI might assist them, but that's vastly going to continue to be human-driven. But all the things that are not critical, and having a physical interaction, more than half of them will be things that are automated by technology. And I think it will be a good thing, and it will make it, particularly in I think you'll see the biggest difference in under-resourced communities worldwide when you think about the work that it takes to provide high quality care. Um, it's heavily administrative, and that technology will be able to navigate people and communicate with patients in a way that just doesn't exist today.
I guess, I mean, I'll just paint a picture from the Bangladesh side. So I think what sort of Kwame said is quite important, is that yes, whether we like it, whether we do not like it, a lot of administrative, a lot of healthcare delivery, AI will have a strong kind of presence in that. So Bangladesh has only one doctor for 10,000 patients in sort of rural Bangladesh, whereas in any developing countries, sort of in developed countries like US, UK, it's about 23 to 35 for 10,000 patients. So AI and technology, I'm not going to separate AI separately. AI and technology kind of in that sweet spot, it has the ability to solve that primary care delivery problem, because that's the only way to scale it. The traditional investment, a kind of lower middle income country like Bangladesh, with a lot of huge corruption issues, even in next 5-10 decades, it will not be able to kind of invest enough so that everybody has access. So I think technology and AI hand in hand has the ability to solve that problem. The question is whether we'd be able to build that inclusive solution that kind of enable these people to take advantage of this is the key kind of thing. And I think for us, 5-10 years down the line, I think at the moment we are doing an evaluation as a part of the Google's kind of sustainable startup development impact academy, is that how much is our impact in urban areas and how much is our impact in rural areas. So if we 10 years down the line, of the lowest 40 million of Bangladeshi who are in the lowest socioeconomic group, if we can facilitate even a million, I think in the Bangladeshi context, million is not much. Even if we can facilitate in 10 years, million virtual consultations for this lower socioeconomic group, I think we'll take that as a big win, that we have managed to kind of lift over a large community of people who would have otherwise have not accessed regular healthcare. And that would have been, their health condition would have deteriorated. They would have been the secondary in the emergency care, either with severe disabilities in their life.
And where do you see yourself in 10 years? All of you, what have you accomplished?
I'll take the last question a little bit with all of the things that they said. I'd say, like, if we look back 10 years, there was no way you could think that we'll be here today. The growth has been exponential. It's really not known. So I would say this growth is going to be even more faster. Now we're going like that. It's very hard to say what's going to be there. I would see some regulations coming up from many different governments and trying to normalize what's going on in this sphere, or interfere, normalize and interfere, both probably. And the other thing is, Mamun said about primary care. I think we're going to move to preventive care faster than we think right now. For my vision, my goal, I'm very women-centric solutions that we'll be creating. So I think like there would be a women-centric agent, every woman's hand, or whoever has smartphone that take care of their own healthcare. Women are neglected and under-discussed and not taken care by even medical text. They are not represented. So all this data that we see, all the medical history that we are seeing, will be able to create that text that is catered for women physiology and body. So that's where my vision is for next 5 years. Can say about 10 years, we'll see. What was your question? So I can go quickly and then let other stuff. Where I see myself, okay, I see as an agent for accelerating that change. I've been working in AI since it wasn't called AI. I was trained in data mining in college. So I have seen that evolution going from natural language processing tokens to LLM right now, and then transformer in computer vision and everything. So I like to be part of that. I also like to be part of the regulation, writing the regulation, writing the policies so that it's equitable and have some say in that one. That's how.
Further from what Mo shared, I think for us in 10 years' time, I resonated very much with the point that we simply won't know what's to come in 10 years' time. The explosion of AI innovations in the past 2 years has been absolutely non-linear. in terms of the trajectory. We would not have predicted 10 years ago that we would be here. But I think in terms of beyond the technical innovations, my hope and what I can see in 10 years' time is a fundamental rethink of how healthcare is delivered and the kinds of care models that are tech-enabled that allow really good doctors, nurses, physiotherapists, healthcare professionals who have very progressive care practices to be able to scale their care philosophy beyond the 24 hours they have in a day, right? There are varying qualities when it comes to healthcare medical professionals. But if we can empower the good practitioners, good doctors who genuinely really care about patient outcomes, and we can be empirical in how we empower these practitioners, I think with AI, with technology, we can really scale their presence to more people. In 10 years' time, I think personally for me, I can foresee myself really doing this work for a long time. I think 10 years is not quite enough given the size of the challenge that we are faced with. Majority of the world's population still does not have access to quality and affordable healthcare. It's not something that I could see. It's a mission that would probably take decades. And I hope technology can accelerate that. So I could see that in my lifetime.
Yeah,
I can
I
just
think, oh, go ahead.
Okay. Very quickly, I'm just going to add what sort of Chiling said, but I can see myself doing this for a very long time. Yes, as an organization, I think a kind of 5 years goal is that we'd like to serve at least 20 million ethnic Bengalis and South Asians across the world. But I guess just to put in perspective that building that semi or somewhat inclusive clinical decision recommendation system, clinical decision support system, it took us 2 years, doctors, epidemiologists, data scientists, to collect data from different resources to build a clinical recommendation system that works for ethnic Bengalis. They are just one segment of the population in the society. There are many, many of these ethno-linguistic groups across South Asia where they're, because of absence of their data, most of the European database recommendation system are biased. So if building for one ethnic subgroups, it takes 2 years, I can see us spending a lot of time on this. So I think, yes, even from my perspective, I'll probably spend a lot more time focusing on building inclusive AI solutions for quite some time.
And I think for AI, a lot of technology is a solution searching for a problem. And over a 10-year time frame, we will find the right use cases for AI to scale throughout healthcare and beyond. And for us specifically, we're gonna blur the line. Right now, being healthy and healthcare are two different things. What we're gonna do with technology is use AI to close the gap and make them one thing. You'll be able to just navigate and communicate with artificial intelligence to just be healthier, to access healthy food, housing, be able to afford medication, navigate your ecosystem in a way that just is incredibly complicated, unnecessarily complicated today. But in 10 years, it will be so much or exponentially easier for any person to be able to access the resources they need or to be able to navigate as far as they can within their ecosystem in the event that those resources don't exist. For example, some places in the US, there is no such thing as affordable housing. But with artificial intelligence, people who historically are in many cases truly left on the street will actually be able to navigate to resources on their own. And I'll give you an example. We worked with a health system in North Carolina where a patient was homeless and he didn't tell the nurses that. Typically, if they tell the nurses, they give them various resources and things like that. But he didn't tell the nurses that. They didn't know that. and they discharged him from the hospital with ThriveLink. And because he doesn't need a smartphone, he's able to just talk over the phone. He had medically tailored meals delivered to him at a car wash where he picked them up, and he followed up. The artificial intelligence helped him understand where to find his medication. So he followed his own care plan. He actually finished the care plan that was designed for him by being able to just have that conversation. And so that's just one of thousands of use cases where we're going to begin to be able to see people who today are not able to access healthcare and health well-being overall because of the barriers. And artificial intelligence is going to remove many of those barriers.
Amazing. I think that brings us to the end of our hour. It's been an absolute pleasure. And I think something that has come out conclusively from all of your contributions, but also from the work that you are doing, what we really need is not the hype of AI, but we need the complementarity of AI and NI, so natural intelligence, and in particular, the values that underpin whatever prosocial AI can mean, and what actually depends on making AI not just another catalyst of capitalism, but of the best for people and planet. So hybrid intelligence is the name of the game, not artificial intelligence. But it was an absolute pleasure, and I wish you the very, very best and look forward to hearing in the future about your amazing journeys as they continue into the future.